the whole cuff starts ripping off, and then you have really a devastating problem of you have no function of that shoulder. So rotator cuff tears can be very problematic. The rotator cuff is huge.
Dude, and as a surgeon, I can tell you, talk about important. It's my bread and butter.
Right.
Hello. Welcome to the Dr. Gill Show. This is where we talk about medical matters that matter to you. My guest today is Dr. Pat Smith. Welcome to the show, Pat.
Hey, thanks, Gil. Glad to be here.
Pat is my colleague, and he's my friend, and he's my orthopedic surgeon. I have a lot of fondness for Pat. When we maybe talk about, when we get to shoulders, I'll show you the little scars that Pat left on my body where he put me back together. And Pat is a local renowned orthopedic surgeon and specialist in sports medicine.
Thank you, Gil. Appreciate it. Been doing this a long time. Another thing Pat and I share in common is the University of Michigan. I went to University of Michigan undergraduate. Pat went undergrad, medical school, and orthopedic residency. So you're even more of a Michigander than I am. Yeah, pretty well connected there. You know, in our family grew up in Detroit. We're fortunate to have that great school accessible to us, and all 6 of my brothers and sisters went there.
Oh, wow.
Mom and Dad went there. My mother was actually a regent of the university for 8 years there, so we were pretty indoctrinated into Go Blue, and went to those football games since I was about 5 years old, and the Bo Schembechler, Woody Hayes era, so I grew up watching some amazing football.
Yeah, we share that in common, Pat. Now, Pat, you are like the premier sports medicine orthopedic surgeon here in Columbia, Missouri. You've been at the Columbia Orthopaedic Group for over 35 years. You are in the Missouri, let me say this right, the Missouri Sports Hall of Fame, Pat.
Well, I think some of that's just been doing it a long time, so, you know.
Right. And you have been the head team physician for Missouri sports for over 30 years. You know, we were a Big 12 school. Now we're an SEC school. We've got Division I sports of all varieties, and all of these athletes can experience sports injuries. And I'm hoping today to discuss sports injuries and learn about how you actually repair and fix and treat these very common problems.
Sure.
I remember when I was getting my shoulder worked on and had some post-op visits with you, your phone would go off occasionally. One call was for a gymnast who had torn her Achilles tendon. And being in the waiting room, I've seen high school football players come through, gymnasts. I've seen the whole the gamut of athletes come through your office. So I'm very excited to talk to you about these injuries and how you can fix them in these amazing and ever more minimally invasive ways.
Right.
So for lack of a better system, I'm going to start at the feet. I'm going to start down on the floor and work our way up. So let's talk about the Achilles tendon. Once again, I was there when you got the phone call for this torn tendon. If people don't know, that's that big tendon right above your heel, big rope. And I remember something about lever arms and whatnot. And I'm going to put this up. The lever here is short. The foot out here is long. It must be an incredibly powerful and strong tendon to be able to suffer those incredible forces.
Yeah, it is. And it's interesting now. We're actually seeing more and more of these injuries in our younger athletes.
Huh.
You look at the NFL this year. There's been several high-profile injuries in the NFL with the Achilles tendons. And so part of it is, we have this one group of patients we'll see, kind of middle-aged males playing basketball, the classic move. They say, I just turned and somebody felt like somebody shot me, like in the calf. I had this terrible pain, and they've ruptured their Achilles. And so that's more of a degenerative process in that middle-aged male. But now we're seeing gymnasts, college gymnasts I've taken care of, and even, again, we're talking about pro football players who've had this rupture. So it's a little bit different. It's not necessarily always just an aging type injury.
Interesting. Now, does the tendon tear, or does it tear off of the bone? I think it's the calcaneus. Or where does the injury occur usually?
Well, what happens, so the way this works is your calf muscles, there's two big muscles in your calf, one called the gastrocnemius, the other the soleus, come together and they make this broad tendon that attaches, as you said, to the calcaneus. But it's your push-off. And so there's a tremendous amount of force on there when you're jumping athletes. That's where the gymnastics is such an issue because they're always pushing off so forcefully to do their
landing. Oh, my goodness.
Great forces. So what happens over time is that that tendon can get thin or deteriorate a little bit in terms of micro injury to the tendon fibers and become a bit weaker. So that's one of the theories of how the injury happens as we get older. But in our younger patients, it's just a little bit difficult to know why we're seeing these young ruptures happen because most of these athletes have had no problems with it and they're young. So I think it's more related to the great forces that are placed on that tendon repetitively.
And are maybe the moves getting trickier and more strenuous? Maybe the level of performance is going up over time. I don't know.
It's hard to see. And what's noticed in the NFL this year is a good friend of mine is an orthopedic surgeon named Bob Anderson, who pretty much takes care of most of the foot and ankle injuries in the NFL, has for years, initially from Charlotte. He was up in Green Bay more recently and just moved back to Charlotte. But I was talking to him actually last weekend at a team physician course that I run, and he was talking about in the NFL, what they're seeing now is these drop back moves where the players are just settling back and so they're not really pushing off. They're going back on their leg a little bit. It seems like a different mechanism of injury. So it's a new area of study that really, and again, because of the NFL stuff, it becomes so high profile. Obviously, Aaron Rodgers this year and his injury at the first start of the season.
First start of the season for the Jets, the poor Jets.
Yeah, the Jets are jinxed. But that particular injury really got the conversation going again. And so again, or even in the Super Bowl, the San Francisco linebacker just running out after the halftime and ruptured his Achilles too. So
wow. So you said it feels like you're getting shot. So I figure it. Does your calf ball up? Does it tighten up?
If you watch they love those slow motion videos where they show the injury and then you can see the player's calf.
Must be Charlie horse from hell.
Yeah, exactly. And just immediate pain, and then they can't go.
So it. If it tears all the way, How are you going to fix something like that, Pat?
Well, I think the thing that we've done a lot better, Gil, is we've become really minimally invasive now. And so what we're doing, instead of making a big 4 or 5 inch incision like used to be done in the old days, where there were problems with infection and skin issues, now we just make very small incisions. We're able to pull the tendon back together with some sutures, but done in a minimally invasive way. So the incisions are a lot smaller. Risk of infection, which was a big problem in the past, and skin problems is a lot less now. And I think the athletes are coming back a bit quicker as long as you restore the tension right. The trick for the surgeon for this injury is you got to get the length of that tendon correct. Because if it's not correct and it stretches out, the athlete will lose power in their calf forever. So our job as a surgeon is to really make sure we pull those tendon fibers secure, but yet make the tension right. And again, we're doing it in smaller incisions and less invasive way.
Are you using a permanent suture?
Yes, using a permanent suture. And there's a thing called an internal brace, which is like a bigger type suture that we actually pass through the tendon to help hold it together, kind of an internal splint in addition to sutures.
Is that similar to what's holding my supraspinatus onto my rotator cuff?
Exactly the same material.
So it's a permanent, it's super strong. I call it braided shark line.
Yeah, it's like a tape almost, and it's like a little shoelace almost. So just stronger. It's a broader suture, and it's got a nice weave to it that has some biocompatibility with our own tissues. But it gives us that permanent strength that we need.
So how long does it take till it's strong enough that a person can start rehabbing and maybe go back to their sport of choice?
I still think it's in that 5 to 6 month range, really.
Yeah.
Aaron Rodgers was teasing everybody that he was going to come back. He was throwing footballs at 6 weeks. Everybody's all excited. But he
on a flat foot.
Yeah,
he ain't running and bobbing and weaving.
Yeah, no, he wasn't ready. And I think that, it's really important in Achilles is that make sure that the athlete doesn't excessively stretch their foot. We call it dorsiflexion, up toward, like pulling your ankle up toward your knee, because that's the position that could actually cause it to stretch out. So I'm fairly conservative on that. I'll start moving them early, but I don't let them really do a lot of dorsiflexion until 3 months. So it's typically a 5 to 6 month recovery. Again, because if you go quickly too soon and you stretch that repair out, now you're weak. you're not going to ever get back to the same level. So
bad idea. Bad idea. Now, do you have any inside information on Aaron Rodgers? Is he going to come back?
Yeah,
through the grapevine.
Yeah, I think he'll be back. A friend of mine fixed him in Los Angeles. A good friend of mine did his surgery, and he'll come back. He'll be fine. It's just that I think it was just the whole he's just a different individual, and I think he likes playing games with people in the media. So part of him out there throwing on that one Monday night was no way he was coming back, though.
Gotcha. Now, are there any other injuries to the ankle? Now, I know there are ankle sprains, and let's explain what a sprain is. I believe it's a small tear in ligaments, and ligaments are these structures, these bands that go from bone to bone. Am I saying that right?
You are.
Tendons go from muscle to bone.
Correct.
But ligaments, and I think if you tear them, that's what a sprain is.
Correct.
So anything you do specially for ankle sprains, or I guess full tears? Is there anything else that's common that you fix, Pat?
Yeah, what we see now, what's really popular in the leg press as well, is this term called high ankle sprain. Right?
That was my next question.
So that's the one. So regular, if you roll your ankle and it hurts on the outside of your ankle by the small bone called the fibula, that's just a typical mild sprain that heals fine. This high ankle injury, though, again, seen in sports so much, is where there's a more complex rotational injury to the ankle. It's a ligament injury, just as you said, not bone.
Okay.
High ankle just means it's above the joint. There's a critical articulation between the big bone, the tibia, and the fibula called the syndesmosis, big long word.
Okay.
And that's a strong ligament. And when that gets injured, now there's more instability of the ankle. So that's that term high ankle sprain. In the past, we used to treat these with like a cast and rehab, and it was 6 to 8 weeks. People were out. It was just a devastating injury. So
right, for the season, season-ending injury.
For a season injury. So now we have this specialist surgery called the tightrope surgery that you hear about, which is where we put actually that same tape that we talked about in your shoulder and the Achilles. We run that through a drill hole between the tibia and the fibula and hold it with these two buttons and pull those two bones together to recreate the ligament by way of that tape. And so what that does is immediately gives stability to that injured structure, the syndesmosis between the two bones. So these athletes have improved stability right away, and you can rehab them a lot quicker. And that's like when, the Alabama with Tua, when he had that injury and came back, was able to play in the national championship game after he got hurt late in the season. That was the tightrope procedure that was done. So that's been a major advantage for us in terms of getting these athletes who have that particular injury back quicker. The problem for us as clinicians is, when do you need to do it? Because not all high ankle sprains are the same. Some are more severe than others. But we're being more aggressive these days about doing that tightrope surgery, especially in the athletes, because we know that we can get them back quicker. And also, restoring stability of their ankle is best for them long-term to help avoid later arthritis development.
You just leave it in there.
Leave it in.
Just leave it in there. So now you have a stronger syndesmosis.
Exactly.
Right.
So,
interesting.
So that particular injury, I think the technology of orthopedic development has really changed the landscape for that injury, because we've been able to get players back quicker and safer and restore the stability of their ankle, which, again, is a long-term benefit.
So we're going to move on up to the knee. And since this happened in public, everybody knows the name. I don't know if it was 5 or 6 years ago. Did we have a running back named Josie?
We did. Henry Josie.
Henry Josie. And I don't think I'm violating his privacy or anything. Incredibly explosive running back. He could go left. He could cut one way or the other. And if I'm remembering correctly, he did a super hard cut near the line. I'm trying to think, out of bounds line. He tried to, and you couldn't tell at the time, but apparently he pushed so hard he tore all kinds of stuff in his knee. The knee is so fragile, it only bends one way, it only goes to straight. Right. Should only go to straight. Right. You got these cruciate, which means cross-like ligaments, an amazing evolutionary development. You got ligaments on both sides. You have this patella bone, a sesamoid bone in this huge tendon that goes over it. Frightfully complicated. How do you assess a knee? And then how do you go about fixing all these different moving parts, Pat, that just It baffles me.
You know, fortunately, we don't get that injury that often. Yeah, I can remember that. You know, at the time, Henry, I think he was second in the NCAA in rushing at the time, having a great season.
Yeah.
We were playing Texas. I know exactly what it was about a 10-yard line, and so I missed a block, and he had to make an evasion on the linebacker coming up, and then I could see something happen. His knee went down, and then he was kind of hit, and he was right by our sideline. And normally, I don't go on the field, so Rex Sharp, our head trainer, usually will go out and assess an injury, and I would never go on the field unless it's something real serious. And I was close to the sideline, and I remember, you know, I got the call from Rex, we've got to look at this, because when we went out to see him, I could tell that his knee was totally unstable. This wasn't just a little, you know, no little injury, but it wasn't just an ACL injury, which is the internal ligament here all the time, the anterior cruciate ligament that's really commonly torn.
Right.
I could tell right away that his knee was actually out of place, and I could tell that there was a big problem. So we immediately called for the cart, you know, to get him off the field. And then when we brought him into the locker room, then I could get a little better examination. I knew right away that he probably almost dislocated his knee, which means he tore multiple ligaments. And what made his injury more difficult for me, Gil, was that in addition to tearing the ligaments on the inside, the ACL, and the outside, the MCL, he ruptured what we call the patellar tendon.
No.
So the patellar tendon is what holds you together.
Another huge tendon. So you've gone from Achilles to patella.
Yeah. So that's the tendon that allows you to straighten your knee. And if you don't have a patellar tendon, you can't walk. It's you know. So now I'm in a situation where he's got, two ligaments for sure torn, ruptured patellar tendon, and probably meniscus. There's two pads in your joint called the meniscus. Okay. So we worry about that as well. So that was a Saturday, of course, game day for us, and then we got an MRI on him Saturday night, and then I'm looking at even more damage to his joint because, again, the meniscus were both torn. And the one meniscus, we call the lateral meniscus on the outside of the knee, I couldn't even see it on the MRI. It was so displaced. So obviously you're looking at a thoroughbred athlete, great football player for us, great kid, Henry from Texas, just a super young man, and his mom, and so a question what to do. So that was a very difficult situation for me. That was a Saturday, and then I decided that we better get him fixed, at least some of which we could do as much as we could, especially that patellar tendon as soon as possible. So, that was a Saturday night of me kind of surgically planning how I was going to approach everything. Right. And we actually operated on the next day, Sunday, and did, some of his surgery because there was so much damage. It was difficult to put him together completely. So we ended up fixing his patellar tendon first and then also fixing his meniscus. And the one meniscus I mentioned was completely displaced. And I've never seen it before. I had to retract the meniscus from behind the femoral condyle, the femur bone, put it back in, put some stitches in because the meniscus is really an important part of your joint. If you lose meniscus, that really increases your risk for arthritis. So, we fixed that meniscus, the lateral, fixed the medial meniscus, fixed his MCL and his patellar tendon, and figured, okay, that's enough surgery. We'll come back later to do the ACL surgery. Okay. So that was stage one. So we ended up going through that surgery, rehabbed him for a while. Things looked like they were doing pretty well. Then, we came back and then subsequently did the next surgery for the ACL surgery. We had to come back and do his ACL surgery later. So Henry went through just an amazing amount of rehab. Wonderful young man, just stay positive. And, it all turned out well. I mean, he ended up, if you remember that season when the game that was really a highlight to watch him was we beat Texas A&M at our place. And if you might remember, it was late in the game and it was a tight ball game. And this is for us to go to win the East for the SEC to get to the SEC championship. And he made a cut at about the 20-yard line and he went by the guy and scored a touchdown. So that was the game-winning touchdown. We beat Texas A&M at home. So that was
with Johnny Football and quarterback? Who was Johnny Football?
Yeah, he might have been there. Yeah, that could have been when.
Forgetting his last name, I'll always remember Johnny Football.
Manziel.
Yes.
He might have been the quarterback there. So we beat A&M, and then we went to the SEC championship. So, Henry came back, and he the sad part of that story was he got picked up by Philadelphia for the NFL. He was the leading rusher in preseason in the NFL that next year. Wow! And somehow he gets cut on the last day. He was Philly had him. He's the leading rusher. He get cuts, and everybody loved him in Philly because Philly loves a a battler, right? You're
Sure.
from the East Coast, Jersey
Sure.
guy. Well, you know, Philly's the same way. They just love the story
Yeah.
of this kid coming back and terrible injury. We led the preseason in rushing, but he got cut at the last day, and then he ended up in the Canadian Football League. He played a couple years in the CFL. So, but Henry was just a really good kid. That was just a devastating injury, but he did the hard part. He came back. So,
well, you did the overhaul. You put him back together, and he was able to play again. That's just amazing, Pat. So, what kind of advancements have you seen in your career in knee surgery? Obviously, now I'll just tell people an ACL. They used to make these huge. You used to make these huge incisions to do ACL, and then they got these little jigs, and then there was a smaller hole, and then a smaller hole, until you can do an ACL just through little incisions now, right?
Right. We've come a long way, and I think that, you know, I've been really interested in the anterior cruciate ligament ACL, and that's been my focus of research for really the past 8 years or so, working on a technique to help prevent patients and athletes from re-injuring themselves. Okay, so on the problem scale, if you tear your anterior cruciate ligament and you're a young person, male or female, you know, under the age of 21, say, your chance of re-injuring that ligament is pretty high. Some studies up to 20% re-injury, so that just because you get your ACL fixed doesn't mean it's going to hold. So one of our big challenges in sports medicine is that athletes get their ACL reconstructed, which is typically where we put a tendon graft to replace the ACL. So I sometimes can suture the native ACL for what we call repair to save it, but not always. So most time we have to take a tendon, meaning we take a tendon from elsewhere in the knee, either from the patellar tendon,
right,
or we might take a tendon behind your knee called the hamstring tendon, or
really?
we might take part of what's called the quad tendon above your knee. But basically, it's taking that tendon from one other place and transplanting it in the middle of the knee to replace the ACL.
And the donor site kind of grows back.
Donor site goes back, and that's fine. But the problem is these are tendons, not ligaments. They're not exactly the same tissue. They work well, but this re-tear rate is a real problem. So being an ACL surgeon, you know, what I have to tell you is if I fix your ACL and it works forever, then that's pretty good for your knee. If you have an ACL reconstruction, and I do, and you re-tear it and I redo it, it doesn't matter whoever your surgeon is, you never do as well with what we call revision surgery on the ACL as you would do if it was primarily done and stayed intact. So one of my goals in life here as a knee surgeon and a sports surgeon, and particularly an ACL surgeon, was I would like to have all my patients do well and never re-tear it.
One and done.
One and done. So I embarked on this mission about 8 years ago now it's been, where I looked at using this small tape that we've talked about that I mentioned in your shoulder.
Right.
This tape is called a suture tape. It's about 2 millimeters wide and 0.5 millimeter thick. And I had some interest in this because the tape idea of what's called an internal brace developed out of Scotland. A friend of mine developed this for ankle sprains. He was using this tape, and he called it an internal brace. And I thought, what if we somehow could figure out, could we put this into the knee, particularly to protect the ACL? So I ended up doing 3 canine studies actually here at the University of Missouri with Dr. Jimmy Cook, an orthopedic veterinarian and colleague of mine. And so we studied this tape to see if it would be kind of safe in a dog. The dog actually, ACL is very close to the human, so it's a very good study for
good model.
Good model. So we showed that it would be safe to do. And then I did about 4 biomechanical studies where we looked at some cadavers and we put the tape on the ACL and we tested it to see what it would do. And what we found in the cadaver lab, Gil, is that the tape actually protected the ACL from high stress. It would be like a safety belt to take the load off the ACL if there was a high stress placed on it. So the stress that might tear the ACL, the tape was protective. So with that data, I had what we call translational studies in the dog model. Then I had the biomechanical studies, and I said, okay, I'm going to start putting my patients. So I ended up putting it in my ACL patients. I started putting the tape in, explaining it to the patient and their family. Listen, I studied this.
So you put in a tendon and the tape.
Exactly.
Make it extra strong.
Right, but it's kind of like a seatbelt. So it's there. So in your car, your seatbelt's a little loose. You slam on the brakes, it grabs you. It's the same concept. So the nice thing for me now is that come full circle in our world of science. I want to be a scientist. You know, you have to prove your clinical data, like your clinical results. So, okay, I said I did the dog studies, fine. I did the biomechanical studies and the cadavers, fine. But now what I've been able to do is close the loop. So in the past year, I've published 5 clinical studies now on my patients that we've followed up for over 2 years, some up to 5 years, looking at what are the results. So what I mentioned to you earlier, the risk of re-tearing your ACL in a young person is anywhere between 5 and 20%, sometimes even 28%, 30%. What we've shown in my data, my patient population, my re-tear rate with the tape, I'd like to say it's 0. It's not 0, but it's less than 1% right now in terms of
that's an order of magnitude better, easily.
Yeah. So for me, in my lifetime of 38 years doing this, that's been the biggest thing that I feel like I can look back and say, listen, if we can show, and we have shown that this tape makes a difference as a paradigm shift for ACL surgery. So for me, this internal brace concept, the seatbelt concept of the tape has been extremely rewarding for my patients. Because I just don't want anybody to re-tear. If I do their ACL, I want to do it right first time, have it last forever. And it looks like this tape is allowing us to do that, which is really
well, I'm going to call it the Smith procedure.
No.
But it'll live forever.
But we just I had to finish it. I had to get the data done, and so I have to get a kudos to my research assistant, Adam Daniels, a physician that works with me that's really helped me collect this data. It's hard to publish, Gil. You know that.
Oh yeah.
I mean, in our world, you got to have peer review, and that's what this is. These are peer-reviewed articles that are accepted in our scientific literature in orthopedics. That the tape of the internal brace is protective for the ACL from re-tear.
That's fantastic. Let's move our way up the leg, up the thigh to the hip. Now the hip, a whole nother world. Now we have colleagues, and I'll be having some of your partners on to talk about total joint sometime. They're all so busy; it's hard to get them here.
Exactly.
I'll get one. I'm going to get one of them, Pat. But the hip can be injured. And there are things you can do to repair it. Now, tell me about what's special about the hip. I know there's a labrum. I know there's a ball and socket. What are things that go wrong with the hip, Pat, and what can you do to fix them?
Well, the hip is an interesting area that's kind of just, I would say, maybe more or less recently discovered, if you will, because we've learned now that we can actually scope the hip. You hear about scope procedures, which are little incisions, which we've done for the knee and shoulder for a long time.
Right.
Well, the hip has now been opened up because of the scope. So now through the little incisions, the hip joint can be assessed arthroscopically. So it's a deep joint, but once the technique was figured out how to do that, then they started recognizing the injuries in the hip, particularly what we call the labrum you mentioned, which is like a cartilage in the hip, which can frequently be torn in athletics. And now arthroscopically, it can be repaired with sutures. And so now minimally invasive, these hip injuries, which can be devastating, can be repaired arthroscopically. So that's been a big benefit for the athletes. And also a lot of sports, we see a lot of problems with we call impingement, where there's the hip bone can kind of rub on the cup of the hip. So the ball and socket can impinge, and you get like a bony bump there. And so those can be removed with the scope again, shave the bone spurs down. And so it's really opened up a whole avenue of treatment for people that were having hip disorders that would in the past just, would have affected their performance, and maybe they couldn't go and they were done playing. But now, again, being minimally invasive, the hip arthroscopy, the small incisions have really changed the landscape of dealing with hip injuries now.
Wow, I didn't know that. I always learn so much from these talks, Pat. That's fascinating. So let's work our way up. Now, you don't do much spine yourself, right? You say that for your spine partners, right?
It's a whole specialty in itself, Gil. So I don't do spine. So I stick to the extremities. I do ankle, knee, shoulder, elbow. I do quite a bit of elbow stuff. And then our throwers, we see a lot of elbow injuries.
So let's go to the arm then. I'm going to start out here at the hand. Are there many injuries, orthopedic injuries in the hand that are new or innovative?
Yeah, I think that, quite a few things. I mean, the hand is frequently injured, very common. And so fractures now are being fixed with much smaller implants. And so the whole thing with these smaller, everything's become small.
Right.
And so less invasive, so immediate motion. So the days of like breaking a bone and being in a cast for 4 to 6 weeks, gone. So things are fixed, fractures are fixed. We have the athletes move their hand right away to avoid stiffness. So it's really a total game changer in terms of return to play because of our aggressiveness in fixing things now, especially the athletes. And it allows for earlier motion, better return to function, and quicker, ultimate return, like I say, to play, which is very important for these athletes.
Right. Now let's work our way up to wrist. Anything new in the wrist world?
Yeah, I think that, again, there's some of this internal bracing that we've talked about in the knee. People are starting to do some of this for some of wrist injuries, where there's ligament injuries in the wrist, which in the past, when you would just try to suture the native ligaments with like just sutures, it didn't hold very well, Gil. So they tended to stretch out. So now people are augmenting, like they'll suture a torn ligament in the wrist and put the tape across there, that same tape that we've been talking about. It's kind of just metamorphed into multiple joints now, because people are seeing the advantage of basically what we're doing here, if you think about it, is we're repairing Mother Nature's torn ligaments, and then we're putting this tape, this internal brace, to help protect it, right? We're protecting what we've sutured. In the process, we're finding out it makes for a quicker recovery and less chance for stretching of the initial repair, so better outcomes.
Wow. Now, isn't one of the bones of the wrist terribly supplied with blood? Is it the scaphoid or something?
Scaphoid.
It's a scaphoid bone. Just has terrible blood supply, hard to heal.
Right. Still tricky. Yeah.
Still tricky.
Yeah, they're still, they'll do bone grafting. If you have a scaphoid fracture, frequently they'll put a screw in there.
Okay.
But sometimes you have to put bone in there, to help it heal. It's just a problem bone to begin with. But again, that's something you don't want to do. Don't break your scaphoid.
Just don't do it.
That's a bad one.
So work our way up to the elbow. Everybody's heard of Tommy John surgery. I have no clue what that is. So tell me, what kind of injuries do you see in the elbow, and what can you do for them, Pat?
The elbow is problematic for us, Gail. I'm an elbow surgeon, and what we've seen is it's almost an epidemic right now with injuries to the elbow. And what we're talking about when you hear about Tommy John, Tommy John was a left-handed pitcher for Los Angeles Dodgers many years ago, and he tore up his elbow. What happens when a thrower is there's incredible forces on the inside part of your elbow when you release the ball.
Okay.
Right through there.
Right in there.
Right. And that's called the ulnar collateral ligament, or UCL, which is the primary stabilizer for the inside of the elbow. And so that ended careers in the past all the time. And so Tommy John had a surgeon named Frank Jobe out of Los Angeles, and Dr. Jobe pioneered this technique where he took a tendon from the wrist area, and he transferred that tendon up to remake that ligament.
Okay.
So he did that first surgery was in Tommy John. And Tommy John actually came back from, he couldn't throw, couldn't pitch at all, came back and actually became an all-star, had a really long career. So correspondingly, the name of this surgery, what we call UCL reconstruction, is now called the Tommy John. But what I'm saying about epidemic, Gil, is I'm seeing 14, 15-year-old kids tearing this ligament. So the problem is in our world right now is overuse. It's an overuse problem where kids are playing, they might be playing as 2 or 3 summer teams, and they're playing their high school team, and they're just throwing too much. And so this problem of tearing the ligament is really become epidemic, because, it used to be just a major league problem. Athletes that were throwing hard, every 4 days, pitchers, but now we're seeing younger and younger people tearing this UCL, and we're having to do reconstructions. It's a big operation for teenagers. So I think, prevention-wise, it's a number of pitches is a big problem, and then also the mechanics of how kids throw. We know that if you have a poor throwing motion and your elbow drops down, and you would open up your torso too soon, it puts more force on it, increases that risk. In Major League Baseball, the number one reason that the pitchers tear their UCL is velocity. So when you see these pitchers go over 100, okay, that's what Shohei Ohtani just when he threw 103, last year. And then he tore his UCL. Just had his second surgery on his UCL. So we'll see where he comes back in terms of pitching. Obviously, still a great hitter, but so it's velocity is a big problem. So trying to throw real hard. I think another thing that's happened is weighted balls are an issue. Kids are taking a heavier ball, thinking that I'll throw a heavy ball, make me stronger. That's become an issue with overstressing this poor ligament.
Don't do that.
Don't do it. Don't do a weighted ball.
If you're in Little League, do not use weighted balls.
Don't use weighted balls. Mom and dads, watch their pitch count and stick to it. You don't want to tear your medial elbow as a youngster. But I do quite a bit of these Tommy John surgeries where we have, basically it's like doing an ACL in the knee. We'd have to take a tendon graft. They go through the healing, typically it's 9 to 12 months before you're back to throw again. So it's really an issue.
I've never had good shoulder. Now, by the way, the tendon, is it that palmaris longus,
Correct.
that extra tendon?
Yes, sir.
That most people have?
From the wrist, take
I'll
that.
tell you a personal story. I remember I was a young man. I was in New Jersey. We have the boardwalk. And you have these various boardwalk things, swing the hammer, ring the bell, spin the wheel, get the stuffed animal, little rifles, shoot the targets and, get your prize. And they had a speed gun and some balls, right? They give you 3 baseballs and throw it as hard as you could. I'm a young man. I haven't torn up my shoulder yet. And I figured, if I'm just going to throw one as hard as I can, right? I'm going to make 100 miles an hour. I mean, I'm not doing this all day. I bet you if I throw it as hard as I can, I'll get 90, 100 miles an hour. I'll never forget. Young man, tall, fit. I throw it as hard as I can. 66.
Right.
66, and it hurt for 2 weeks.
That's exactly.
So this technique, the reason I'm telling this story is clearly throwing it hard ain't the way to do it. It's getting a good coach.
Right.
And learning how to do the mechanics is what you're telling us, right?
Right. And it's not really even its arm strength. It's all about lower body. You got to have strong legs and strong hips as well, because that really takes the force off the elbow. So if some guy just country strong and just throws it with bad mechanics, he's going to tear his UCL. He may be good for a year, but he's going to lose it. So that whole idea of proper throwing mechanics, especially in our youth. So for young players, or hope their coaches that are listening, really pay attention to the throwing mechanics. Video now is so easy with everybody's phone. Just take a video.
Sure,
it's really easy to see. And look what their mechanics look like, where their arm slot is, because you can really see how they can put the increased force on the inside of the elbow. And Gil, it's just important for me when I fix somebody. I always tell my patients, I go, listen, you've got a bad injury, you've torn your UCL, we got to fix it. Okay, I have to do a good operation. Number one. Number two, you have to do a good rehab to regain your range of motion and strength with therapy afterwards.
Right.
And number three, you have to have proper biomechanics when you return to throw. Otherwise, you'll tear the graft. I mean, you can, and that's happened where people have retorn a reconstruction because, again, the mechanics aren't correct. So it's really a multifactorial situation of preventing this injury. But it's just, I'm just making this point in our youth. I'm seeing younger and younger patients coming in my clinic with a UCL tear or this ulnar collateral ligament tear that we're talking about. And it's devastating. You just want to operate on 16-year-olds. It's not good.
Wow. Like they say, Pat, if nothing changes, nothing changes.
Correct. 100%.
Wow. So let's work our way up to the shoulder, something near and dear to my heart. Once again, you put my shoulder back together. Shoulder is horribly complex. Oh, my goodness. Of all the joints, I find it the most difficult to understand. You've got these outer muscles. You got a deltoid that you'd think would do most of this motion, and the bicep pulling this way, tricep this way. You got your pec. Oh, it's sounding difficult all of a sudden. Now you got a lat pulling back. But then there are these muscles that attach onto the cuff, which is the end. So imagine we got a long bone here. There's kind of a ball at the end. You've got 5 muscles attaching to the top of the humerus. They're doing these more subtle motions, these rotations, these kind of things that are not controlled by these big muscles that you would think. So these are very fragile muscles and prone to injury. Is this true?
Big problem. And the tendons you're talking about, the rotator cuff, are the tendons that are attaching to give you your power. And again, they're
these,
deep.
right?
Yeah.
I remember that from anatomy. There's got 5.
Yeah. And they're holding in the one in the front, and you've got your bicep tendon is kind of part of that deal. And then
I think one of those biceps.
Yeah, supraspinous, infraspinous, we call it teres minor, and it's a cuff around that we call the humeral head. The job of the rotator cuff is to basically center the ball of your shoulder, the head, in the socket, so that the larger muscles can do their thing. So it basically restores the fulcrum. So what happens to us is the tendons of the rotator cuff tend to deteriorate with time. And become weaker, a bit degenerative. Some are traumatic injuries. This winter I've seen several, slip and falls in the ice, body weight gets caught on that arm, sudden force, and it just rips the tendon.
With me, it was falling on my side like this. Tore that supraspinatus.
Exactly, because you're contracting to protect and you land, and then the force lengthens a tendon and it tears.
And it tears.
And it's devastating because it now causes pain, especially at night. Night pain is really the most common symptom I see with patients with a torn rotator cuff. Night pain, weakness overhead. They just don't have the strength. And what happens is once that starts tearing, it just continues to tear. And if you don't do something, you can end up in a situation where the whole cuff starts ripping off, and then you have really a devastating problem of you have no function of that shoulder. So rotator cuff tears can be very problematic.
Yeah, so somehow Facebook and YouTube know whenever I have a problem, there's an ad for it. I won't get into all the personal problems that happen when you get older, but there's always an ad for what's bothering me. I don't know how they do it. They know how often I get up at night. I don't know.
Yeah.
But when I was going through my shoulder stuff, there were these videos for rehab. Oh, just do this exercise and it'll fix your rotator cuff. That doesn't make any sense to me. If it's tearing and starting to go, nothing's just going to pull that tendon back like a bee sting. Like they say, put a bee sting there and it'll pull back together.
I mean,
right?
some people can tolerate it without getting it fixed.
Okay, there you go. There's the word.
Tolerate, but it's not necessarily. It's not going to heal the tissue. And the natural history, in fact, has been looked at. Once you tear the rotator cuff, we frequently see this diagnosed with MRI is how we do it. The magnetic resonance imaging or MRI can show us the tendon. If you watch them over time, over a 5-year period, the tears get larger and larger. I mean, that's just it makes sense.
Yeah, it makes sense. I don't see any other way.
Right. So what we've been able to do with the arthroscopic techniques, again, minimally invasive. In the old days, Gil, when I started my practice and we'd have to fix rotator cuffs, we'd have to make a big incision.
Big. I've seen the scars.
Pull the muscle down, get in there. It was hard surgery to do for us. Patients hated it, very painful, struggled. I remember when I transitioned, 25 years ago to start using the scope, I had some patients that I had fixed their one shoulder with an open incision, did fine, came back, now they tore their other side, and I said, we got to fix this. I go, no way, doc.
No way.
I'm not letting you do this to me again. I lived through this once.
Right.
But I said, listen, this is with the scope. It's going to be different. And so what happened is ultimately I had 4 or 5 of these patients I did with a scope, and they just came back and go, oh, why didn't you do this before? Because it was
called a control group.
Right,
This is group A, group B.
But once I could convince them to let me do it with a scope, then they came back and said, wow, this was really easy because they remembered the pain that they went through with the big open surgery. So the arthroscopic techniques have really made it a lot easier for the patients to outpatient, fix it. Still out of rehab, as you know. It's
man.
6 weeks in a brace. And,
I'm going to tell you, Pat, people say it would be 6 weeks, 8 weeks. No, it's a year.
Yeah.
It's a year till you're really feeling good again.
Yeah, and that's just it's like in a knee with an ACL. Our athletes tell us it's a year.
Yeah, it's a year.
It's a very important part of our anatomy. The rotator cuff is huge.
Dude, and as a surgeon, I can tell you, talk about important. It's my bread and butter.
Right, and every day you're using it. So getting it fixed is critical. So I think that. But doing it with a scope, I think, has made that a lot better as well, too.
Oh, I'm so glad. I'm so glad. And I'm a guy, scars are sexy. But these are, I can't even show them off. I say, where's my scar? And then, well, you can barely see it.
Right.
In fact, when I'm going to do a laparoscopic surgery on someone else, I'll actually pull up my sleeve and say, ma'am, your scar on your tummy or your belly button is going to look just like this. And they go, what scar? Right?
Yeah, that's good. Good.
That's
good.
a beautiful thing.
Thanks for that.
Yeah. Oh, big shout out to you, Pat. Is there anything else new in shoulder surgery? Are you putting tapes or internal braces in the shoulder now?
Well, we're doing some things now. As we've talked about rotator cuff, we got into this problem of some cuffs get unrepairable, what we call massive tears. So we've been doing some things lately with grafts where we're taking some donor tissue. Actually, we use donor skin grafts. So donors have given up their skin, cadavers that they take the skin as actually we use as a graft to try to help replace the rotator cuff.
Skin is strong stuff.
Really
Leather is skin.
100%.
Leather is skin. In fact, when we do abdominal surgery, I remember the first things I learned, you think that the gristle layer is the strongest. In fact, if you put big retention sutures through the skin, that's actually the strongest layer.
It is. And so they have techniques now where they can take the skin, take all the DNA out, so there's no reaction to it, so it's a pure graft. And we're using that as kind of a restraint to hold the head down. So there's because some of these patients have a massive cuff tear and they don't want to have like a prosthesis. There's a thing called a reverse shoulder, which is a big prosthesis you do if you don't have a rotator cuff. But they don't last forever. They're not for people in their 50s. So grafting has become an area of research that's been going on to try to see if there's ways that we can make up or substitute for rotator cuff deficiency by using a graft. And we're doing it arthroscopically, less invasive. So, a lot of these techniques are evolving that we're just trying to make patients' lives better by preserving their own joint still and avoid like the metal and plastic of like
I know an artificial shoulder, it's a big deal. You're not going to be lifting weights again. It's just, well, can you get it through life? Can you ride and drive the car or something? So these, even an artificial shoulder, it's not like a native shoulder.
Exactly. So I think, for us, that this area of this grafting has come into play a lot now recently to try to substitute for these patients that have really bad rotator cuff problems.
So you foresee continued advancement?
Oh, I do.
In shoulder.
I do. I think we got a lot to do, understanding the shoulder still. We're better. We're getting way better. But for our patients, we're all, as you're in the business with me. We're trying to do this for our patients, right?
Yeah, that's why we get up in the morning.
Right. The patients are hurting. They're having problems. Can we fix them? Can we do it minimally invasive and in such a way that's going to last and let them have productive lives and not be disabled? So I think that the technology is continuing to progress. And I think that's really to the benefit of our patients. And so for us, the minimally invasive, as we've talked in this whole session, arthroscopically, small incisions, we just continue to take that to the next level. And I think the shoulder is really an area that we've shown that to be true.
Fantastic. And I'm living proof of that. So, Pat, are there any other topics in sports medicine, surgical repair of injuries that I haven't covered? I tried to kind of go through the body. Are there any other things going on that we need to know about?
There's one other big area that we should talk, and that's biologics. And so there's everybody knows out there, they hear about stem cells and they hear about platelets, and I think this is the new frontier. And I've been involved in actually I did the first FDA study showing the safety of using platelets, or what we call PRP, platelet-rich plasma, for treatment of knee arthritis. I did the first study here in Columbia where it was an FDA-sanctioned study, which we had to show if it was safe or not. So we published that, and I published that back in 2016. And what we did is we looked at a group of patients with knee osteoarthritis, and half the patients blinded, I gave them saline, and the other half I gave them their platelets.
So let's talk about how you get the platelets. You take some blood. In fact, you did this for me too, and I'm very grateful. Let's talk about that. You take a syringe of blood. I don't know, is it 30 cc?
Yeah, 60? 15 cc's.
50, so it's a half an ounce.
Yep.
And then you spin it.
Correct.
And the red cells go to the bottom. The plasma goes to the top. But there's something right in between, isn't there? What is that?
Yeah, that buffy coat layer.
The buffy coat.
Right. The buffy coat, when you spin it, it's all based on density. So when you spin the blood, the heavier cells drop out because of their dense. That'd be red blood cells and white blood cells. And then the platelets rise, and you get this nice layer of platelet-rich plasma. And that platelets have what are called growth factors.
Yes.
So when you inject platelets in PRP, what's happening is the platelets open up and release their growth factors, and that's what has the healing potential. And so we've been using it. Again, we did the study to show that it was safe in knee osteoarthritis. In my group of patients, it's interesting. Every patient, we followed them for a year ago, every patient that got the platelets had a tremendous positive response, less pain.
Versus placebo.
The placebo, which was cool for my paper, was the placebo patients were better for the first 2 months, which makes sense because placebo effect is a scientifically proven.
Yeah, it's a real thing.
Real thing. People give them a shot, they think something happened, they get better. Well, at 2 months they were better, statistically better. Then they deteriorated down 6 months to a year, whereas the PRP or the platelet group continue to have improvement up to a year. We do a special survey called a WOMAC, which is a kind of a pain function type score. And so we showed every patient, which was amazing. Every patient had the platelets was better. So that was, once that study has been done, and there's been other patients that we've studied since then with platelets, and other researchers have also studied it. But PRP for knee arthritis has been definitely something that, I gave it in your shoulder. We do it sometimes.
And it has helped. Thank you.
I've had it in my own knee joint. I have an arthritic knee myself from an old injury. So,
right.
But it's much safer than cortisone or steroid. You don't want to do that.
And it's your own cells.
It's your own cells.
It's coming out of your body, goes right back in a few minutes later.
Right. So I think that's going to be a huge area. Stem cells is kind of still out there a little bit. The problem, unfortunately, is we have some clinics and such that promise a lot without any data to any science. And, some clinics are charging exorbitant amounts of money for harvest of stem cells from your bone marrow and telling you it's going to cure arthritis and it's going to make you a new ACL and make you a new meniscus. Those are unfounded claims, of course, and that's a kind of the bad part of medicine that's out there, Gil. That I see.
We see it in fertility.
There's
clinics offering very expensive treatments.
Yeah, exactly. And unfortunately, patients, want to live forever. Regenerative medicine, this whole field of regenerative medicine appeals to people. Well, gosh, if I can do this, and the problem is it's, not covered with insurance. It's cash, and I hate to see it. I hate to see people spend their money on a treatment that has not been proven because somebody's a good salesman, and unfortunately that's out there.
Sure.
So that's one of the reasons why I did the study I did, because I want to try to get this, hopefully, ultimately, so it's covered by insurance at a reasonable rate. So, it's what's fair is fair, but, you don't need to be charging excessive money, especially when the techniques are not totally proven. So we need the science. That's where I'm at. I'm a scientist. I want to make sure what we do is right for our patients, safe for our patients. But again, the efficacy has to be there, not just like a sales pitch that, I can make you younger, I can cure arthritis by doing the stem cells, because that's not true.
Well, it sounds like you got very robust data and were able to make a very strong scientific conclusion from your data.
That's what we did. So
placebo-controlled, prospective, blinded. Just the gold standard. That's very impressive, Pat. So glad you did that. Well, Pat, that's going to lead us to our final topic here. And if I get a little emotional and tear up, you'll have to excuse me. Pat Smith, Missouri Sports Hall of Fame, team physician for 30 years. You're in your late 60s now, Pat, and apparently a wonderful, and you run a fellowship here in sports medicine. Apparently you've had an offer that's too good to refuse. Tell us a little bit about it, Pat. What is the next chapter in Pat Smith's life?
Well, Gil, I'm a worker. That's what I do. That's what I do best.
Yeah. We're going to die with our boots on, Pat. I know.
That's my deal. So an opportunity come to me. There's a hospital out of New York City called Hospital for Special Surgery, HSS.
Oh, they've been famous out of Cornell in Manhattan for decades.
Yeah, it's the number one orthopedic hospital for years, has been. And so they decided to open up a clinic in Southwest Florida.
Oh, maybe Naples. Pretty sandy beaches and sun.
Maybe Naples, Florida. So they recruited me to run their sports medicine program, which would include research and education, which really appealed to me. And the opportunity, I do work the fellowship here. Now I have 2 fellows that I work with through the University of Missouri in sports medicine training. And so my hope is to start my own fellowship. And we have a wonderful opportunity to, out of the work that I do with a company called Arthrex, which is a sports medicine company that's headquarters in Naples, very close. So the idea is to integrate research and continue that effort of trying to make best treatments for our patients in orthopedic surgery with coordinated effort research there, teach fellows. It's going to be sports oriented. We've already taken the new soccer team, professional soccer team that's coming to Naples. I'll be taking care of them. So
you're going to be the sports physician there too.
I've got to learn a different.
Oh boy, you're not going to let up on the gas pedal one bit, are you?
And I'm an American football guy, so now I got to have to change my course and learn about football,
football,
the rest of the world football. But so we're going to do that. We've got a minor league hockey team we're taking care of, and Florida Gulf Coast University is there, which I'll be helping with the athletes there as well. So it'll be a new practice. I'm going to be seeing patients and doing surgery, kind of building it all up again. But just a wonderful opportunity for me, and hopefully the next chapter. Columbia's been great. I've been here 38 years. I hate to leave my great practice and my patients. But I feel like, this was just an opportunity that I had to accept. There's another challenge, Gil. You know how we are. It was just,
I think that's kind of what Jim Harbaugh did. He said, well, I've done it. I've maxed out at the University of Michigan, undergrad, national championship, and I'll go to a different challenge, and he'll go to a different league. So, Pat, I'm going to miss you, but this is a wonderful move for you. Everybody kind of gets closer to Florida when we get older, and I think you deserve that. And I want to thank you for, once again, I'm going to get all choked up. I want to thank you for taking such good care of me, your group for taking such good care of my family. I'm sure you've got some young hotshots who've been well-trained who are going to move up and fill your place, but they'll probably never quite fill your shoes, Pat. So thank you for your care, for your service to the University of Missouri and the community. And What a pleasure talking to you today. Thank you so much.
Yeah, it's been a pleasure. Thank you very much.